Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled 6 Expert Tips for Heart Valve Patients. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com nearly 20 years ago in 2006. The mission of our website is really simple. We want to educate and empower patients just like you. And this webinar, which has had over 950 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen-only mode, but I would encourage you to submit your questions in the control panel that's on your screen. And let's look at the agenda for today. I'm going to introduce our featured speakers. We're going to talk about why have this thing called Valve Disease Day. We're going to reveal 6 expert tips. We're then going to dive into a Q&A session. And at the end of the webinar, I'm going to ask you to complete a very quick 5-question survey. So when it comes to the featured speakers today, I am humbled and I'm honored that they are taking time away from their very busy practice at Northwestern Medicine. And who are they? Well, we have with us Dr. Doug Johnston, who's the Chief of Cardiac Surgery at Northwestern. Dr. Johnston, thanks for being with us today.
It's great to be here, Adam.
We've got Dr. Melissa Medina, who's a cardiac surgeon and assistant professor of cardiac surgery at Northwestern Medicine. Dr. Medina, thanks for being here.
Thanks for having us.
Yeah, and all the way from Alaska, we have Dr. Kevin Hodges, who's joining us on his vacation. He is a minimally invasive specialist with a super subspecialty in robotic mitral valve repair. Dr. Hodges, thanks for being here.
Thanks. Wouldn't miss it. Hopefully the connection holds up. So let me know how things are going.
We will. And so I could go on and on about the achievements and accolades of these 3 physicians. They have performed collectively not 50, not 100, not 1,000, but several thousand heart valve procedures. But instead of going into all the research that they've done, all the clinical work that they've done, what I'm going to do, given the agenda, is simply show you this. These are the pictures of the smiling faces from patients at HeartValveSurgery.com who have gone to Northwestern Medicine and had some extraordinary outcomes. Whether it's David or Jesse or Paul or Michelle or Alan or Lawrence, it is wonderful to have Dr. Johnston, Dr. Medina, and Dr. Hodges on the line. I also want to go ahead and I want to congratulate Northwestern Medicine on the 20th anniversary of the Bloom Cardiovascular Institute, which happened last week. I was very lucky to be invited to attend their party in celebration of this incredible accomplishment. And it really is a testament to what happens when good people come together who want to do good things. And I'd also suggest to you, that's what's happening here at HeartValveSurgery.com. As many of you know, one of my passions is helping children in third world countries get cardiac surgery treatment. To date, we've gone ahead and we've helped the 6 children that you see in front of you here in the Philippines and El Salvador and Uganda. And just recently, we helped Nasmiri in Uganda and Daphne. Daphne just had a mitral valve repair. So in the spirit of today, we are a community coming together to learn more about our health and learn more about our heart valve care. Let's talk about this thing called Valve Disease Day. What is it? Well, let's start with the facts. The facts are about 2.5% of the population have some form of heart valve disease. Might be trace, might be mild, might be moderate, might be severe. But it's a good amount of people in the United States. Because the disease is degenerative, you'll notice that as you get older, more people have it. So about 13% of people over the age of 75 have some form of valve disease. This is where Valve Disease Day comes in and awareness. 75% of Americans, they know little to nothing about valve disease. So it's a very unknown disease and it's very insidious because it can be asymptomatic. What makes this even worse is the fact that less than 40% of people with the disease get treatment. And sadly, when you look at the data, about 25,000 people die annually because of a valvular defect. So this is why we're here today. It's to raise awareness to this disease. How are we doing this? Well, back in 2017, we started Heart Valve Disease Awareness Day. And it's a group, it's not Heart Valve Surgery, it's a group of many other folks who are doing this. It's over 100 organizations that have come together. It's recognized by the US Department of Health and Human Services. And to date, I'm very proud to say that we've generated over 1 billion impressions and reached 166 million people, help them learn about what valve disease is and what valve disease isn't. Now, there are some people on this line who may have been diagnosed today. And so to level set for them, I just want to ensure that you know you have 4 valves in your heart. There's the aortic valve and the mitral valve, which are most commonly valves that are treated. Tricuspid valve, which is often referred to as the forgotten valve, but is coming online very quickly with a lot of new technologies to treat that. And then there's the pulmonary valve. The big point I want to make to you, whether you're diagnosed this morning or 15 years ago, you are not alone. There are teams, heart teams, all over the place that are waiting to help you. And today, for example, we have a team of cardiac surgeons. They work with all the folks that you see on the line here today, whether it's cardiologists, interventional cardiologists, valve clinic coordinators. So there are teams in place to help you. And so with that being said, let's get into those 6 expert tips for heart valve patients. I'm going to turn it over to Dr. Doug Johnston.
Great, Adam. We're going to give you some tips that may be a little bit counterintuitive. So we're going to tell you some things that insiders know about how to deal with heart valve disease. And think of this as just a high-level framework for how you think about a diagnosis of valve disease or helping a family member or those kind of things. So let's dive into it, Adam. I'm going to put the next slide up. So tip number 1, heart valve disease diagnosis is a good thing and can save your life. Why is it a good thing? It's a good thing to get a diagnosis. There are so many patients who have heart valve disease without knowing it, and how they get diagnosed can be often kind of random. You may go to your primary care physician and they hear a murmur. Could be a family member that hears a murmur when they're giving you a hug. You might get an echocardiogram for a reason that is not related to the fact that you have valve disease, or maybe something else going on. Or you might have another test like a CT scan or an MRI that can show calcium on a valve. So there are a lot of different ways, but knowing you have valve disease means that we, as your heart team, can help you track it and help you to get the right intervention when you need it. Let's see the next slide. I would say knowledge is power. If you're aware of your disease, you can avoid all the bad downstream things that can happen in terms of damage to your heart, develop debilitating symptoms, and in some cases, and this is fortunately very unusual, sudden death from valve disease. So once you know what you have, we can help you understand it. And for many patients, it may just be an echo once a year to see how your valve is progressing. But it is 2025. It's not 1955. I asked some family members of mine what they thought the risk of dying from a heart operation was if they needed to have a heart operation that wasn't an emergency. And the average number that I heard was 15%. So, and this is like including my mom, who obviously knows that I'm a heart surgeon. I said, really, Mom, you think that 15% of the time people come to my operating room and don't make it out? This is not 1955. Mortality at Northwestern for valve surgery in general is less than 1%. In many cases, it's much less than 1%. And we have a number of ways to help you get better, including some of the minimally invasive techniques that we all focus on. And Kevin in particular focuses on the robotic side. You'll hear from him. And we can often help you get back up and running faster through what's called enhanced recovery after cardiac surgery, or ERAS. So we have a lot of ways to get you through this faster and in a way that will not be a major impediment to your life. So this is a really great picture. This is a very old figure from a very famous paper by Dr. Braunwald, who's one of the kind of most famous cardiologists in valve disease. Basically what it said is, if you have aortic stenosis and you are not intervened on, you don't have a valve replacement, that your survival, your likelihood to live after you develop symptoms, which are severe, and fortunately today most people don't get those, your survival is worse than most cancers. Most people are dead within a few years if they don't get treated. So severe valve disease is a very lethal problem. Now, this is back dates back to the early 60s when there wasn't really good therapy for a lot of patients with severe valve disease. But this is what happens when we don't do anything about it. Fortunately, as we said, we have a lot of good things we can do. Surgery is very safe. Transcatheter procedures for valve disease are advancing very quickly. So we got a lot of tools we can bring to bear. So you should not be the person who falls off the cliff here on the right side of the picture. We want you to be the person who is alive, talking to your grandchildren about how you had a valve operation 50 years ago. And I think that's what the situation that many of you will be in. Next slide. At Northwestern, we are growing very fast in terms of the number of patients we take care of. Our mortality rate, as I said, for valve surgery, where there are a lot of different ways to measure this, but one operation that people use to benchmark a valve program is what's the mortality rate for isolated aortic valve replacement. Nationally, it's about 2%. In our hospital, it is well under 1% and has been for the last several years. And as I said, we have a lot of different ways to do those operations, but many of the people who come to us for valve surgery are coming from far away because either they can't get the same quality, and that's an important thing we'll talk about, asking about what the quality is of the center that you're talking to, or they can't get the same type of procedures. So we're very happy to talk to patients from anywhere in the country. I spend most of my days when I'm not in the operating room doing telehealth visits with people from all over the place, often with very challenging cardiac problems, but sometimes there are people with a new diagnosis who just want to know what we can offer them surgically. So we're happy to see you, even if you don't live right here in Chicago, and especially if you don't live right here in Chicago. If you're in Alaska like Kevin, where one of my recent patients came from. Next slide. All right, I'm going to hand it over to my colleague, Dr. Melissa Medina, for tip number 2.
Thanks, Doug. That was great. You brought up a lot of really great talking points. I'm going to piggyback off some of that. And the tip I'm going to talk about is your medical team may not offer all the type of heart valve therapies that there is there to be out there. Next slide. Okay, so I think we can all acknowledge that after being diagnosed with any issue with your heart, stressful diagnosis to have, but of course it's extremely important for patients and you all to understand what's going on so you can make the best choice for you. It can be overwhelming, not only the thought of needing heart surgery itself, but sometimes having these various options open to you can be hard to navigate. Especially at centers like at Northwestern and other big volume centers, the medical teams can help you consider the various types of options and figure out what factors and help you choose what's right for you. For example, the treatment options for various valve pathologies can include, for root replacements, for example, traditional root replacements, Ross's, valve sparing root replacements, or even the Ozaki procedure. For various approaches to valve pathologies, as Doug and Kevin are going to be alluding to, there's the minimally invasive approaches with small incisions on your chest versus using even smaller incisions that Kevin does with the robot. Also various transcatheter options that are there with mitral clips and TAVRs and various procedures that can be done with our interventional colleagues are also available. So I think it's, like I mentioned earlier, it's very important for all of these therapies to be at least explained to you and your families to kind of figure out what's the best route that you can take. And this is sort of what I alluded to earlier. There's just a picture of different types of aortic valve reconstruction. All of these surgeries can be offered here at Northwestern. The Ross procedure here, as well as the valve sparing, are two of the very common operations that we can offer as well.
Yeah, and Dr. Medina, if I could for just a quick second, I think I'm a great case study in this. Because when I was diagnosed with aortic stenosis and a bicuspid aortic valve, the first thing I was told was, well, you can get a cow valve or a pig valve or a mechanical valve. And that was it.
Yeah.
And then I went ahead and I really did some research. I became like my own best advocate to figure out if there wasn't another operation. And that's where I learned about the Ross procedure, which I ended up having done. It's been 20 years now. I'm free from reoperation. I've had no intervention. And it's only because I went to a center that had that skill set for that specific procedure that I've had all these great benefits of durability without blood thinners. And so I'm curious to know, when you have a patient come to you and say, hey, look, I've got aortic valve disease, for example, do you walk them through all of the different options that are available and explain to them why one may be more advantageous than the other?
Yeah, Adam, first I applaud you for, being your own advocate and finding a center that can best serve you. And to your point, absolutely. Whenever I see a patient in clinic who is in need of any sort of valve intervention, I think, first of all, what their comorbidities are, and their lifestyle, especially, and to see what we can offer them, whether that be transcatheter versus if they're young, we can offer various procedures such as the Ross, high volume center for these complex cases as well.
Yeah, well, it's a great point. I just wanted to make sure the patients really understand how this truly feels like it's the golden age of valve therapy. There's so many different options. And let's keep going on. Thanks so much. And let's go over to Dr. Hodges for tip number 3. Thank you.
So this tip is all about empowering patients to make the right decisions for their treatment. And the tip is, let safety and patient outcomes guide your provider selection. So let's go to the next slide. It takes a moment for it to pop up. There we go. So patient advocacy is key. And the first point here says patients often get run over by health systems and established referral patterns for cardiologists. And, what that means is that, really there are a number of factors that influence how referrals are made for important interventions like heart valve surgery. Those things might be referring providers' opinions about what is the right procedure. It may be opinions about who is the right provider to do that. It may be that they have established relationships within a large health system where they're encouraged to refer locally. There's a number of things that go into this, but ultimately what matters most is that patients get the right option for them. And what that means is that patients should feel empowered, not just to get opinions from their cardiologists or their primary care doctors, who they rightly trust very much, but to seek second opinions and to use resources like HeartValveSurgery.com to understand the range of options available, both in terms of providers, center type, and procedures. I think this comment at the end, "This is not a haircut," is really important. I mean, this is often the biggest medical procedure that a patient will have in their life, and one of the most consequential things that will ever happen to them. So you need to make sure, not just that you're making the right choice, but that you're confident in your medical team. I think about this a lot, that making a decision about what procedure to have or what surgeon to choose is difficult. There's not any one way to know what is the right choice. But I would say, there are resources like the STS database, that's the Society of Thoracic Surgeons, that ranks centers on quality. There are, all of the news rankings like US News and World Report. And then there are great resources like HeartValveSurgery.com that know all of this very well and help direct you in some sort of objective way to the right choice. So let's go to the next slide here. We have a list of some sample questions. So that when you as a patient are seeing a provider to discuss your heart valve intervention, you can sort of think of these things as good ways to go. And I would emphasize that, especially at a place like Northwestern, where we see a lot of patients in second opinions, there's no question that's out of bounds. We want patients to ask questions. We want them to ask, what often they perceive as tough questions. We welcome that because it allows us to make sure that we're both on the same page. So, one easy one is, what type of treatment do you recommend and why? I see a lot of patients with mitral valve disease, and sometimes patients have heard that certain valves should be replaced rather than repaired. And often I have a very strong feeling in the other direction. If a patient, comes to me and says this valve must be replaced, I've heard that from X, Y, or Z. I tell them, or I feel very strongly that, this is a valve repair situation. Other situations like an aortic valve disease, we go through a number of options and discuss, what might be the right specific procedure for a given patient. It's fair to ask, what are the patient outcomes for this specific treatment? Not just big pictures, but specifically in patients who have had a valve repair or a Ross or Robotic, how are your patients doing? Are there less invasive treatments to consider? In mitral space. There's transcatheter edge-to-edge repair. People have heard the term MitraClip, which is an emerging technology that we're still learning more about. In our practice, we feel it's not right for everybody, but it's a great tool for some. And we, you know, it's important to talk through these things and to make sure patients know the range of options, even if it may not be the right choice. How long have you performed heart surgery? How many heart valve operations have you done? People shouldn't shy away from that. Even if they're a relatively inexperienced surgeon, you know, they should, you know, give an objective picture of their practice, their training, and why they feel that they could do a great job for you. This next one I think is really great. Do you specialize in aortic, mitral, tricuspid, or pulmonary surgery? Just because a surgeon may be extremely famous, they may be at an extremely famous center, doesn't mean that they're the right surgeon for a particular problem. So I think it's important to ask your surgeon, do you specialize in the exact problem that I have? Do you treat patients with my specific form of heart disease is essentially the same? What are the greatest risks? And you know, people think of, I always say people are worried about death, stroke, and dialysis, but there's a lot of different risks and a lot of different considerations, and to talk through the specific nuanced concerns for each operation, I think is essential. What do you expect as the best result from this operation? And I think what do you expect as the worst result from this operation? You know, because I think the vast majority of cases, the best result is the same. It's a return to totally normal quality of life. It's an improvement or elimination of symptoms. And ideally a good durable result that's thought out for an individual patient, but that's not true of everybody. And I think that has to do with, you know, where people start, with their risk factors or other medical problems. And I think having a really clear picture of what you're getting into is super important. And then the last one is, do you think I will need another operation in the future? Adam, you alluded to this with your Ross procedure, that you've now been 20 years without an intervention, which is a fantastic result. But I think, you know, everything's a little bit different, and understanding the likelihood of, you know, needing something else in the future is important to set expectations in the future. So, you know, the point of this one, again, be willing to ask questions. You know, no provider, no surgeon should ever be offended by your questions or put off by that. I think that's a big red flag. You know, we're here to answer your questions. We're here to give second opinions when called upon. And we are all here to encourage you to get as many opinions as you need to be comfortable with the decisions that you make for your own care.
Dr. Hodges, these are fantastic questions. What we're going to do, just so everybody on the line, you don't have to write them all down, but I know what it's like to have white coat anxiety and not have some courage sometimes to ask physicians questions that need to be answered. We're going to post all these online after the webinar so that you don't have to write them down now. You can just reflect on them at a later time. And if need be, you can go ahead and just print them and bring them to your upcoming consult if you need. Let's go over to the next tip. Dr. Johnston?
So counterintuitive tip number 4, realize that you will have heart valve disease for life. This is a tough one. I'm not sure I like the term heart valve disease, because for many patients, and you heard Adam's story, you have a heart valve issue. You have a heart valve, I don't know, what's the best thing you have to think about. But for many patients who have a successful procedure for their heart valve disease, or are earlier in the stage of disease, basically what it means is you're going to have a lot of years of a normal life where you might need an appointment once a year to get an echocardiogram. And that's really a pretty good thing to have going on with your heart. There are types of heart disease that are very serious, that have implications about your life expectancy and those kind of things. Many patients with heart valve disease can live a normal life expectancy and totally normal lifestyle. So while you will have to think about your heart valve for your life, it may not be something that you would really think of as disease. So next slide. Why is this important? We are all living longer lives. Life expectancy and the expectation of having a very active life is increasing. So, you know, we have lots of patients in their 70s, 80s, even 90s who are very active people, and where it's not just the life expectancy, but it's the quality of life that matters. I operated on a 94-year-old gentleman who was a very active pickleball player and had a bad mitral valve problem last year. You might think, why are you operating on somebody who's 94? Well, he wanted to get back to playing his level of pickleball, and he was otherwise 100% healthy. So that's a fixable problem in somebody who has probably many more years of life. So while lots of things we can do for the heart are not permanent, many of the things we can do, like valve repairs, like the Ross procedure, like tissue valve replacements, And even mechanical valves can, while the machine itself may last a human lifetime, they can stop working for a number of reasons. In general, these fixes are very durable, while they may not be permanent. And if they do fail in the future, we have lots of options to treat them that are also very safe. The reason we talk about having valve disease for life is it means when you have a procedure, it doesn't mean you're done. We want you to have a relationship with a physician or team. It doesn't necessarily even have to be a cardiologist. Some patients that I've operated on have excellent PCPs and they get the patient in for their testing every year. But you need to have regular surveillance of your valve, and you need to have people that you trust when there's a change. So many patients have asked us questions about findings on an echo or other study. It's important that the people you go to are not, to Kevin's point, kind of one trick pony. You don't want to hear, this is the only thing we can do for you. What you want to hear is, here are the options, here are the relative risks and benefits, and how does this fit in with what you want? That's the first question I ask my patients. What do you want to get out of this? So shared decision making means you are the center of that decision. And if you're young, and young these days can be a lot older than we used to think, you might need a second or a third procedure of some sort in your life. You might have a totally normal lifestyle in between those procedures, but it's important that we plan for what the options are. And we want to think about the fact that technology is going to change a lot in the next couple decades of your life. So we don't want to pigeonhole ourselves into only one option. So having this conversation of what happens next is very important.
Right. Dr. Johnston, I love the story about the 94-year-old patient wanting to continue playing pickleball. I'm sure patients on the line are wondering, as I plan for this lifetime management of the disease, I'm curious, you've done thousands of heart valve operations. What is the most amount of valve therapies that you've done for one patient, if you can remember?
Well, it wasn't all me, but I'll tell you two interesting ones. So I operated on a lady who was in her 80s who had an atrial septal defect repair by Dr. Kirkland when she was 15 years old. We operated on her more than 60 or almost 70 years after her first operation. So that was the longest interval between two operations that I'm aware of. We did a double valve replacement and she did very well. I've done an eighth time operation on a patient. The first operations were not all done by me, but somebody who had their first operation in childhood. And that's the most in my experience. There probably have been people who've had more, but it's just a testament to the fact that people can get through multiple interventions in their life, and our job is to try to make the distance between those interventions as far as possible. We're not saying we want to give you a lot of surgery, but if it keeps you doing what you're doing, if it gets you back to the life that you want to live, we have a lot of options to re-intervene when things go wrong.
All right, thanks so much.
Well, this is kind of an eye chart. We'll have this in the slides for you folks to look at after the webinar, but just to look at how we think about a decision tree for patients who have a particular type of valve disease. There are a lot of criteria here. I think the main reason to put this in here is so you recognize the fact, if somebody tells you, you have a tight valve, you need an operation, it's never that simple, right? There are a lot of factors that we look at, including who are you as a patient, how old are you, how active, what else is going on with your heart, that go into the decision making. And there's a lot of evidence. These green, yellow, red is based on the evidence that people will do better versus the evidence that people will do worse. And at a very minimum, your team should be able to explain to you how they're using guidelines like this to help make decisions in your care. So how do I get to 90? Well, play a lot of pickleball, I guess this is the answer. But this is the question you should be talking about with your team.
Okay, so I'll take tip number 5. So the recovery from heart valve surgery should not be rushed. Next slide. I think, between all of us, we get this question a lot. How long do I expect to stay in the hospital? How long should I take off work? How long do I refrain? Or how long can I start playing pickleball again, or the activities that make you happy? I think we could all sort of acknowledge that normal can have a very different meaning for all of us and for different people. it's difficult not to compare what you're about to have done to what your neighbor had or what your friend had or what your uncle went through when they had their bypass surgery or valve surgery. But I think something important to keep in mind is that people recover in different ways and taking various amounts of time. Something also to take into consideration is how sick you are going into surgery and what symptoms you were feeling leading up to it. Everybody's expectations are always going to be a little bit different. We talked about the different approaches to valve surgery, and given how far our specialty has come over the years, as we've sort of said before, we can offer many options, but that also means that each option or therapy, whether that be undergoing something minimally invasive with a smaller incision or a small puncture site in your groin versus a traditional incision, with a sternotomy, each can have various recovery times. Regardless of the approach, though, I think heart surgery is heart surgery and complications are an inherent reality. A good mindset, at least what I tell my patients is, forward progress is a positive, and not rushing to feel quote unquote normal is just something to be aware of. And because it does vary from person to person, it's different for all of us. But it's important to listen to yourself. I encourage, all of our patients to walk after surgery, but no, obviously, no, if you're tired, take a break. But each day, progress, walking more and more distances. I think forward progress is a great mindset to have after surgery.
Yeah, Dr. Medina, for the patients who maybe just recently diagnosed or maybe have been in the waiting room for some time or getting ready to go into surgery tomorrow, you mentioned that complications are a reality following these procedures. Can you maybe talk about what some of those complications may be and their prevalence?
Sure. I think with any operation, not only heart surgery, inherent to any operation is a risk of infection. There's, of course, bleeding. We have just, if me, Doug, or Tevin, healthy individuals undergoing heart surgery, we have the inherent risk just being put on the bypass machine for renal failure or strokes, all very minimal risks, but they're there nonetheless. And so I think it's important to discuss those with our patients and just have the overall picture so that they know what to expect going into surgery.
Yeah, and thank you for setting that expectation, because I often get emails from patients that are completely wrecked, that they've had a complication, whether it's atrial fibrillation or something else, and they feel like they've done something wrong. And that's just not the situation. This is just a part of cardiac surgery, or any surgery for that matter. So thanks so much. Let's move on to the tip number 6.
Thanks, Adam. Just quickly, I really appreciate that last tip from Melissa. I think a lot of the things you mentioned, AFib, things like fluid, accumulation, maybe needing to even have a fluid drain from around your lung or something, are perceived sometimes by patients as big setbacks or signs that things aren't going well. And I think it's something that we can occasionally do better as surgeons, is to prepare people for those things that can sometimes be a part of a very successful procedure and part of progress. So thank you for adding that. My tip is that second opinions can be very helpful for patients. We go to the next slide, of course. This ties back a little bit to my last one, but I think second opinions are essential. The need for heart surgery and the decision about this can be very difficult for patients to process, for their family and friends to process. It can feel like a lot is being thrown at you at once. Especially if you're asymptomatic. To the second point, you may feel totally normal, and suddenly a physician is telling you that you need to have open heart surgery, and it can sort of feel like, the world is crashing down. And sometimes getting multiple opinions, even if you get an opinion from 2 providers that say exactly the same thing, can help you to really sort of settle into what's going on. To the very first point that Doug made, getting these diagnoses sometimes feels like this sort of, why me? How could this have happened? Patients with valve surgery often don't have the same risk factors as, say, a coronary patient. It's not because you smoked. It's not because you lived an unhealthy lifestyle. It's often a genetic thing. It's the way you were born. But to understand that, this is a important diagnosis that's made. There's so many options that can get people back to normal, often with minimal risk. And often just hearing this from multiple providers, who ideally are all encouraging and talking through the process, I think can be very valuable. And that's, to the validation point. But to the last one, I think is really why people get second opinions most of the time is consider a second opinion to ensure you're on the right track for the management of your issue. I think we've hit throughout this webinar on the issue that for any given valve problem, there are a number of treatment options. Providers, whether they be surgeons or cardiologists, may be biased in favor of one or the other. I think everybody, in our field, universally, I may be a little bit of an optimist, but I think that everybody is looking out for patients. And if they give you one opinion or one procedure over another, it's out of that motivation. But the reality is that there's often a lot of things you don't always get the whole picture from one person or one institution, and seeking multiple opinions can really help you understand what your problem is, what the options are, and what the path forward will be. So I encourage any patient to seek a second opinion. We at Northwestern are always happy to provide that, even if you come right out and say you're going to stay with your other surgeon. That's fine. We're here to provide you that validation, or maybe give you a little information you didn't have before. And we're always happy when our patients seek second opinions about what we've told them. It's all about patient empowerment and making an informed decision that you're happy and comfortable with moving forward.
Yeah, and Dr. Hodges, and for the folks on the line, what you just talked about was my experience. I felt like I had done something wrong. I felt like my world was crashing down on me. I didn't know what to do, who to trust on the front end. I didn't know what procedure to have. But it wasn't until I got the second opinion that I realized it validated the first opinion. And that's when I got a certain amount of calmness over what would be next for me in terms of taking care of my valvular disease. So I love this slide. Thanks so much for putting it together about second opinions. And now with the tips, we've gone through those. Next part of the agenda is we are going to answer your questions. And we've gotten 38 come on the webinar, and we've already had some other ones come in before. So why don't we get right to them with some really quick rapid fire. For the physicians, the panelists, if you see a question that you'd like to answer, jump in, and we can also do some round table as well if you'd like to add to the commentary. Let's start, and this is a fascinating one because it comes in from Laura. And Dr. Johnston, just so you know, this is your patient. She asks, "Hi, Adam. I had my aortic valve replaced and an aneurysm on my ascending aorta repaired by Dr. Johnston just in November. I've read a lot about how long it takes for the sternum to heal, but I've been unable to find anything specifically on how long it takes for the heart to be completely healed after a heart valve replacement. Can one of the doctors tell me a general time frame?"
Well, Laura, great to hear from you. Maybe we should have had this conversation before surgery. I'm sorry that I didn't talk about the heart itself healing, but in general, the amazing thing about heart surgery is, your heart has to work pretty normally right away after the operation. And as far as most things that people would go back to doing, like exercise, as you probably know, we recommend going back to aerobic exercise as soon as you can do it after surgery. So the things that we might be concerned about for an aneurysm, so increased pressure on the aorta, are kind of the same things we'd be concerned about with your sternum. So for a sternotomy procedure, we'd say no heavy lifting for 6 weeks. 6 weeks is a time frame when everything that's healing is likely to be about 85-90% of normal strength. And so that's why it's okay to go back to normal activity. But truthfully, I've never heard of a situation where someone exercising or doing something like that caused a problem with healing of the heart. The heart is amazingly fast at healing even a big operation like an aneurysm repair. So it's very quick after the surgery.
Great. Let's move on to Sherry's question about heart valve replacement durability. She says, "Hi, Adam. I had a bicuspid aortic valve replacement with an Inspiris Rosalia. That's a tissue valve made by Edwards Life Sciences in the summer of 2023. When I had my checkup last fall, they said that the leaflets appear to be mildly thickened. There is also a mild leakage of the new valve. Is this common or normal to have such a thing happen in the short amount of time after surgery?"
I can jump on that one. So this is something that I don't know that it's not happening more necessarily, but I think we're becoming more aware of this. It started actually with TAVR valves, some of these leaflet thickening phenomenons after bioprosthetic aortic valve replacement. We are starting to understand it more and more. In some cases, this has to do with what we call subclinical or, not enough to cause serious valve dysfunction, but still there, thrombosis of the aortic valve. And if that's what's suspected, oftentimes a short treatment with a blood thinner can be indicated, or just monitoring, depending on the severity of the situation and other factors involved. But I think it's something we're seeing more and more, and it's often seen as alarming, but very rarely does this need to or lead to a need for a reintervention. So I think it's a good thing to have a conversation with your cardiologist about, but I think it's fairly unlikely that it will lead to a redo aortic valve replacement in the near future. I think we got a lot of options before that.
Great. Here's a question from Eileen, and it gets back to what we've already talked about, is conflicting information for patients. She says, for my mitral valve, I've had 2 cardiologists, and I've just recently been told, one of them, to go to my surgeon and have a catheterization because of recent results of an echo. However, my other expert, who is a seasoned and highly skilled cardiologist, explained to me why he feels I should continue to watch and wait. I have no symptoms and I'm energetic. I don't want to compromise my longevity. What should I do?
I can start with that one, and then I'll, let Kevin, the mitral expert, sort of chime in with his 2 thoughts here. But I think, a lot of it, Eileen, probably has to do with what they're seeing on the initial echoes, and what the pathology of your mitral valve is. If they're seeing a change in your echo, there are certain echo criteria, certain measurements that we look at that even if you're asymptomatic, we want to make sure it doesn't get worse. And so, Kevin, if you want to add in, please do. But I think, if you're asymptomatic and you say you're energetic, they may be seeing certain criteria that you might be meeting on your echoes, that lead them to want to check out other aspects of your heart, like your coronaries, that make you need a cath.
Yeah, I'm not sure exactly what the pathology in question is, but if this were, for instance, mitral valve prolapse and a leaky mitral valve from that issue, we get this scenario all the time in our clinic. And I think what a lot of it comes from is historically, 10, 20 years ago, the approach to mitral valve regurgitation from prolapse was to watch this with serial echocardiograms until we saw signs of left ventricular dysfunction or if the patients develop symptoms. But based on a lot of data over the last several years, there's been a big move over the last 5 years or so toward earlier intervention in valves that can be repaired. And when that repair is durable, patients often have a better result by being proactive about their severe mitral valve dysfunction to prevent bad things like heart failure, atrial fibrillation, pulmonary hypertension, or other complications that may arise if you wait too long and may prevent patients from going back to a normal life trajectory. So often early intervention is appropriate, but it all depends on the specifics of the situation.
Great. Here's a question about timing heart valve surgery. Mary asks, at what % blockage should aortic valve replacement take place? Do symptoms bring on quicker replacement, or do you have to wait until your body reacts?
Well, I'll take a swing at that one. So to echo what Kevin just said, the old school thinking about any valve disease was almost no matter how bad the valve looks on echo, we should wait until the heart starts to fail or the patient gets symptomatic to operate. That is definitely no longer true. So let's just debunk that whole theory. You may hear this from, in particular, older physicians who trained in the 80s and 90s. That thought process made a lot of sense in the era when heart surgery was much riskier. There was a time when having an open heart operation did carry a risk of mortality of like 10% for healthy people. That's a long time ago now. And so the risk benefit ratio was different. But we know now that for almost any type of valve disease, if the narrowing or stenosis or the leak or regurgitation is severe, that most patients do better if they have an operation before they become symptomatic. As Melissa said, there are some echo criteria we can look at that aren't as kind of rough as just is the heart failing, that will tell us at what point a patient might benefit from an earlier operation. But in general, for people who are otherwise in decent shape, it's the echo that ought to guide us before patients really feel short of breath or they're passing out or get dizzy or chest pain. So long story short, don't wait until your body reacts. Talk to a valve expert and make sure you've got good imaging.
Great. Let's move on. Anything else, Dr. Hodges, Dr. Medina, you'd like to add?
Totally agree.
Fantastic. Let's go on to the next one, which is about multiple types of heart valve disease. David says, I'm 72 and was diagnosed with bicuspid aortic valve 10 years ago. Annual echoes since then have not shown it to need attention. However, this year, my echo identified a problem with the anterior leaflet in my mitral valve, causing severe regurgitation. I am asymptomatic. The current thought from my cardiologist is to repair mitral valve and surgically replace a bicuspid aortic valve with a tissue valve during an open procedure. Any thoughts on my condition or possible procedures?
Yeah, that's a great question. This comes up fairly frequently. And I think if the mitral valve regurgitation is severe and the valve can be repaired, then that ought to guide the timing of intervention. A good durable mitral valve repair ought to last this patient for the rest of his life. And if that's the case, then intervention is reasonable. It's a little bit tricky to know what to do with the bicuspid aortic valve. If the valve looks perfect, that means there's no subcalcification. It opens and closes normally and doesn't leak. It's hard to replace a valve that is perfectly functional. I had this the other day with a young patient in a totally normal bicuspid valve, and it's hard to justify replacing that valve. But in a 72-year-old patient, if there's any sign of bicuspid valve dysfunction, that valve is likely to wear out over the course of the patient's lifetime, and replacement with a tissue valve makes a lot of sense because that tissue valve will likely last 15 years or so, and is a good platform for a valve-in-valve TAVR procedure through the groin, whereas a bicuspid aortic valve may not ultimately be a very good landing spot for a TAVR valve. So replacing the valve, if it's moderately dysfunctional now, actually probably sets David up for the best long-term management.
Great. Let's move on to Mel's question, who at YouTube asks, will a mitral tear heal on its own? It's moderate to severe regurgitation, and I have shortness of breath.
Mel, some people call me Mel too, so I'll take this question. So I think, will a mitral tear heal on its own? So tear, I guess to me means, is the tear in the valve leaflet itself, or is it calling it a ruptured cord that's like making an appearance of a tear? But if they're saying it's moderate to severe and you're, as we sort of alluded to before, you're already having some shortness of breath, it may be affecting you, obviously symptomatically. And so it might be prudent to get that further evaluated.
Great. And so moving over, this has come up a couple times when we've talked about new technologies as valve-in-valve operations. John asks, because the procedure is relatively new, there is scant literature on aortic valve-in-valve replacements for tissue valves. What can you tell us about the efficacy and longevity of valve-in-valve replacements?
Well, John, you hit the nail on the head. There is scant data. This is a new procedure. What we know about valve-in-valve is done at an institution that does a lot of these, takes careful measurements of the valve that you have in place, and understands what the potential risks are. This can be a very safe procedure. What we don't know is how long it lasts and what some of the longer term issues can be with valve-in-valve. There was a recent study that was presented at one of the major meetings this year comparing a redo surgical valve replacement with valve-in-valve that showed that the outcomes for a redo surgery were better. Those are sometimes tough to interpret because you're comparing all comers, and we know that valve-in-valve is very dependent on the type of valve you had to start with, the type of valve-in-valve TAVR, the sizing, and how the procedure is done. But I would say jury's still out. This is one that really benefits from having an expert heart team, and you should be presented with both options. For a healthy patient, the discussion should be what is going to be best for you, valve-in-valve or redo surgery. And in many cases, we may not have great data, but we ought to be able to tell you the relative safety, at least, of each procedure.
Great. This one just comes in from YouTube from Vikram, who asks about the Ross procedure. He says, can a patient who had an aortic mechanical valve replacement get a reoperation if needed with the Ross procedure?
The short answer to that question is oftentimes yes. And, what you need to do is have a team that has excellent imaging, a multidisciplinary team, and an expert Ross surgeon like Chris Malazeri, who's here at Northwestern, who can look at the anatomy of what was done to the aortic valve the first time, but also the quality of the pulmonic valve, which is ultimately what's used to replace the aortic valve the second time around. Generally speaking, having had a first operation with a valve replacement does not preclude a Ross procedure the second time around. So if there's some issue with the mechanical aortic valve and a reoperation's on the horizon, I think this is a great thing to consider.
Great. Thanks, Dr. Hodges. Here's specific to athletic considerations for people with needing surgery. Greg asks, I have a cuspid aortic valve with regurgitation. I'm an ex-NCAA hockey player back in the 1980s. I was finally diagnosed after years of irregular heartbeat and past misdiagnosis. I continue to play hockey as a 65-year-old with ex-NHLers here in Canada. I'm doing okay, but concerned and would like to know if at this stage of my life, minimally invasive surgery may still be an option and possibly valve repair. My ejection fraction is 65, 98% oxygen, and an average 52 beats per minute.
So Greg, I think the fact that you're still playing hockey at 65 is quite impressive. And I think you're the picture of health, it sounds like. So to answer your first question, is minimally invasive surgery still an option? I think so. Both Kevin and Doug, do various approaches for minimally invasive valve surgery, possibly valve repair. I think that would depend on the pathology of your valve, as well as what we actually see in the operating room. Your ejection fraction is normal, and so you being an athlete, your heart rate is probably on par with you being a ex NCAA hockey player. So yeah, I think you'd be a fine candidate for minimally invasive surgery.
Great. Moving over to Carol, who says, lately I've been seeing YouTube videos with doctors who are saying statins, beta blockers may not be best for heart patients. My question is, how do the doctors in this webinar feel about beta blockers, statins, diuretics, and blood thinners? Are there natural alternatives?
Well, that's a great question, Carol. This is one that comes up a lot. People will say, I just saw that this new diet will take care of my coronary disease and my valve disease, and I shouldn't have to take any medication again. And what I always tell patients is, I would love to see the data. That would be amazing. For some of these problems, like hypercholesterolemia, high cholesterol that statins treat, there's a great natural alternative, which is low cholesterol diet and exercise. And lots of people can control their cholesterol that way and don't require any drugs. Exercise also helps with hypertension. And so that is one way that people can come off of drugs like beta blockers, but not everyone can control the full extent of their disease with lifestyle modifications or diet or those kind of things. So this is one where you really benefit from having a preventative cardiologist or a preventive medicine doc who really understands the alternatives. What I would say is there's no magic bullet. There's no natural supplement that takes care of all of these issues. And some patients really need these medications. For instance, certain patients with heart failure can only live on diuretics. I mean, they're a lifesaver and a lifestyle saver. And if you have a mechanical valve, you absolutely have to be on Coumadin. I mean, that is the difference between life and death. So sometimes, I guess, is the best response, and that will probably evolve over time. But these drugs, as much as people like to come off them, do keep people alive.
Great. Thanks, Dr. Johnston. We're going to move past this as we've already talked about it. Let's move over to mechanical valves because we've had some discussion about it, but not a lot. William asks, I have an aortic regent mechanical heart valve that was inserted in September of 2020 at Baylor St. Luke's Hospital. Wondering what maintenance I should be doing for the valve, and will other blood thinners be approved for valve use instead of warfarin/Coumadin?
Yeah, great question, Adam. So hopefully this is a fairly easy one. What maintenance should you be doing besides occasional echocardiograms for surveillance of valve function and cardiac function? None, and that's actually the benefit of mechanical aortic valves. Not everybody's willing or able to take a blood thinner, but for those that are, and especially young patients, these are great prostheses. The prosthesis that he has is a great one, and it lasts for a very long time. And the other one, I unfortunately don't have the answer. Hopefully, he's looking for is that are there an alternative for warfarin at this time? And the short answer is no. There have been some studies that have tried other agents in head-to-head comparisons with warfarin, and the results were not good. The studies had to be stopped due to more blood clots. And so right now, there's not an alternative. There's an ongoing study in East Asia looking at this in other sort of populations with mechanical aortic valves. But as of right now, warfarin is the only agent that is been shown to be the safest option for mechanical heart valves.
Great. We're going to talk transcatheter. We're going to go to this question from Mark, and then we got one from Sherry who submitted. Mark asked, do any of the transcatheter devices for valve therapy also treat atrial fibrillation?
I can jump in on this one again if that's okay, because AFib's a passion of mine, I guess you could say, as nerdy as that sounds. And the answer is that they don't treat them in the sense that they don't directly affect people who have AFib. They may help prevent the development of AFib in people who have valve disease but haven't yet developed it. So that's maybe one consideration of that. But I think AFib is a very important consideration for anybody with valve disease when picking a procedure. AFib has been shown to be associated with decreased life expectancy, more strokes, more heart failure. It's a really bad actor. And while transcatheter therapies often are less invasive and have some very clear short-term benefits, the ability to do what's called a maze procedure and a left atrial appendage occlusion at the time of an open heart procedure is a huge advantage in people who have both valve disease and AFib. And I think it's essential that anybody who has AFib brings that up with their surgeon and finds out what is the plan for my AFib. Really, really important.
Yeah, thanks for that, Dr. Hodges. And let's stick on transcatheter. This is from Sherry, who submitted, I'm curious to know if doctors are recommending transcatheter valve replacement for patients under 60 years of age.
So that's a great one. The answer is it depends on what else is going on with the patient. So the data on low risk patients with transcatheter aortic valves in particular, so that's what we have, where we have the most data, is a little confusing. It's often used to say, oh yeah, well, you're 55 years old, you can get a TAVR valve and have a great result. But the average age in the low risk studies was in the mid 70s. So we don't have a lot of data on young patients having transcatheter valves. In particular, one of the considerations is that patients around age 60 tend to have bicuspid aortic valves, and there's some data to suggest that TAVR doesn't work as well in bicuspids. The outcomes are not as good as they are in trileaflet valves. Again, this is one of those areas where it's hard to generalize from transcatheter valve studies done 10 years ago in 80-year-olds to a 60-year-old. It's a very different longevity that we're looking at, very different outcome. So at Northwestern in general, for younger patients, most younger patients with valve disease, we would consider surgery first. The data is more robust for that. That being said, there are people who have reasons why they're higher risk for surgery, or where we expect that other things are going to go wrong with the heart. So a perfect example is radiation heart disease, where if you need a valve replacement of your aortic valve now, chances are your mitral valve is going to be involved in the next 5 years. That's a case where we do recommend TAVR for younger patients, and it doesn't burn any bridges for us for the longer term.
Great. Thanks, Dr. Johnston. We are coming to the end of the hour, but please don't jump off the line. We've got 49 questions, and I know Dr. Johnston, Dr. Hodges, Dr. Medina, in the past, you guys have gone ahead and answered these questions after the webinar. Would that be something that would be possible, and then we can post all the answers that you provide? Is that something the Northwestern team can do?
Absolutely.
Of course.
Sure.
All right. Fantastic. So on that note, before you hang up, I'd like to go ahead and, as we celebrate Heart Valve Day and Heart Month, I want to thank the expert panel today, Dr. Johnston, Dr. Hodges, and Dr. Medina, for being with us. This was a very quick hour. Thanks for all the tips that you shared with the patients in our community. And on that note, I'd like to thank the patients in our community, the families and friends that come together here at HeartValveSurgery.com to really help each other get the best possible outcomes for their valvular therapies. And lastly, what I'd like to do is thank you for the survey. As we wind down the webinar, this will be coming up on your screen as soon as we say goodbye. So once again, Dr. Johnston, Dr. Hodges, and Dr. Medina, thanks for being with us today. Thanks to our community, as we always say here, keep on ticking. Thanks so much, everybody. Have a great rest of your evening.
Thank you.
Adam.
Thanks to
everybody.
our participants.